Shubha Madhyana. Welcome all. So we are meeting after a very long gap. I would like to welcome you all again with the continued sessions of Shalyatantra on Tadvidya Sambhasha. Before we start today's session, we will start with a prayer. Om Namami Dhanvantarim Adidevam Sura Surair Vandita Pada Padmam Loke Jararubhayam Mrityunasham Dataramisham Vividaushadhina Om Shanti Shanti Shanti. Welcome again. So today is the session 14th session of Shalyatantra series on Tadvidya Sambhasha that we are continuing. So until 14th session we have seen various sessions. So the first session was on an introduction on Shalyatantra. The next sessions were a series of sessions on Bhagna, that is the skeletal injuries, and the next session we had just started, I think 1 or 2 sessions on the diseases of the gallbladder. So in the disease, on the sessions of gallbladder, what we have seen until now is the basic anatomy of gallbladder, and I think we had also seen a session on the basic investigation, radiological investigation techniques that we can adopt in diagnosing or in interventioning a case of or the pathology of the gallbladder. So with that we had also seen basic cholecystitis, not cholelithiasis. So cholecystitis and up to its treatment aspect was discussed, cholecystitis along with cholelithiasis too. So today, in today's sessions, we will be starting on with the operative intervention. I think we had seen the conservative intervention for cholelithiasis in the last session. So today we will be seeing the operative intervention. So as all of us know, the operative intervention for, so the topic of discussion is, we'll be continuing with the diseases of gallbladder. So today our main focus will be on the operative intervention. So that is nothing but cholecystectomy. Now, a very small portion before we start with the operative intervention. So we had seen discussed the various etiological factors and how how to diagnose cholecystitis, what causes cholecystitis, all of them in the last class. So there is something common that we have to see is all of these that we discussed were calculus cholecystitis. That is that there is a presence of gallstone in the biliary tree in the gallbladder, because of which there is inflammation of the gallbladder. But we have to see that there is also another component called as acalculous cholecystitis. So now we could think how cholecystitis could happen when there is no presence of, or where there is the absence of gallbladder. How does cholecystitis happen? So for that there are two instances. So the first one is that it is seen that around in 15% of cases, usually acalculous cholecystitis is seen in patients who have undergone in the post-operative period, in patients who have undergone serious injuries or serious intervention, operative intervention for the injury, like in cases of severe trauma. Okay, also in post-operative period after being treated for severe burns. Okay, and also in patients who have undergone coronary artery bypass. So after major surgical interventions, one instance or one chance of the occurrence of acalculous cholecystitis is seen. So usually in this phase, the diagnosis of acalculous cholecystitis is missed because this goes undiagnosed because a USG might be showing a clear biliary tree without the presence of the calculus. So in such cases, we, having a doubt over the cholecystitis to happen in the absence of a calculi is very rare. So that's why usually these patients, they go undiagnosed or the diagnosis goes missed. Now, one thing what we saw is that is the acalculous cholecystitis after major surgery. Now, the second one what we are going to see is something called as typhoid gallbladder. So, this is a term called as typhoid gallbladder. So, what happens usually here is, that is, the person who has a typhoid fever, it is seen that he excretes Salmonella typhi in the bile. So even in such cases, the patient could end up in cholecystitis. So this is called as acalculous cholecystitis. So under acalculous cholecystitis, it is mainly this particular condition is called as typhoid gallbladder. So many of the times what they do, usually these stones, whatever the, when they remove the specimen out, they are discarded very carefully because there are chances of, the bacteria that could spread from it. So usually there are chances where the bacteria can be cultured through the specimen. So that is why they are discarded carefully. So this is one instance of what is called as typhoid gallbladder, and the second one is acute acalculous cholecystitis because of, in the post-operative period following a major operative intervention. So these are the two things. Now moving on further, so now we will see deal with cholecystectomy. So in this cholecystectomy, there are of two types. So one is the laparoscopic technique, the other is the traditional open technique. So first we will discuss on the laparoscopic technique and then we will move on to the open technique. So now before we take a patient to surgery, so the basic pre-operative regimen is to be observed. So this has to be observed. So what are the basic pre-operative regimen? So we have starting from the history taking to, whether the patient is fit for surgery. So a fitness, and then all the general parameters, RBS, the renal function, the liver function, ECG, chest X-ray, then we have the blood, coagulation parameters, a prophylactic antibiotic. In some cases, even a DVT prophylaxis is also given. A DVT prophylaxis. So all of this has to be worked out. So most importantly, along with all of this comes the consent taking. So the entire pre-operative workout has to be done. So once the pre-operative workout has to be done, now moving on to the operative part of it. Now before we start dealing with the laparoscopic cholecystectomy method proper, I would want to first brief on how a laparoscopic technique is done. So how is that basically how is that, irrespective of the underlying condition right now, what are the requirements in that is needed, and how do we actually do a laparoscopic technique, that we will see now. Okay, so as all of us know, so laparoscopy is a minimal access surgery. Unlike the open technique. While in open method, there is a single large incision, and through that single large incision what we have made, we will gain access inside to the cavity. Suppose here the abdominal cavity. So a single large incision is made on the abdominal cavity, and you gain a open access into the abdominal cavity. But here it is a minimal access surgery. Why minimal? We will see now. Okay. So, and another thing what we have to see here is laparoscopic surgery. So it is nothing but the combination of operative creativity, we can call actually, along with modern technology. So in combination of both of this only, a laparoscopic surgery is possible. So it is more or less, it can amply be called as a surgical innovation. Now, what are those few factors that makes laparoscopy, better than the open technique in with respect to certain pathologies? So the first thing is the wound, the measurement of the wound we make with respect to each of this is almost, there is a huge difference. So in case of a open technique, we might have a larger wound, but in case of a laparoscopic technique, it is usually around 1 centimeter incision that we take. Smaller wound is created. So smaller the wound, so better is the management. Smaller the wound, so less is the chance of infection. Smaller the wound, patient recovery is better. So smaller the wound, the somatic damage what we are doing is also less. So once the recovery time is less, so obviously the hospital stay also decreases. So the patient outcome, the quality of patient outcome is better in cases of laparoscopic technique. So it also, in some cases, they also say that the time required is also once the mastery has been gained over the technique. So then compared to the open technique, the laparoscopic technique, it needs lesser time once the the skill is absorbed. Along with that, post-operative complications, usually when the wound is larger, as we discussed already, the wound acquiring infection is also more. Here it is less. The wound dehiscence, all of that happens, complications with respect to the open technique, all of them can be curbed by adopting a laparoscopic technique. So this is the basic advantage of laparoscopic technique over the operative procedure or the open procedure. So now, taken for instance, how the laparoscopic surgery will be started. Now suppose for cholecystectomy itself, so we are doing a laparoscopic technique on the abdominal cavity. So first what they do is, they will create a small sleeve or port. So this is nothing but an incision. Okay, it is called as sleeve or port in the language of laparoscopy. So this is nothing but an incision. So what is the size of this incision? The size of the incision is somewhere around 0.5 centimeter to 1 centimeter. So these are all small incisions. So basically in any in laparoscopic surgery, so there will be one main port or one main sleeve. Okay, so suppose here, considering this is our main port or the sleeve, that is I am making an incision through the skin of the, so this is the abdomen, through the skin of the abdomen we are making an incision which is around 1 centimeter. Okay, so this this one main port will be there in all laparoscopic surgeries. So through this sleeve what we do, we will insert the trocar. Okay, trocar is an instrument like thing through which the laparoscopes or other instruments will be inserted into the body cavity. Okay, so usually in the main port, it is not the laparoscope that is put. Usually in the main port, we always put the camera scope. Okay, so this will be the camera. So it is called as the camera port. Okay. Now, likewise, so suppose now we are doing a laparoscopic method for cholecystectomy. So the area to be focused is here. So usually what we do, one port is not enough. So the surgeon, with respect to the surgery and the condition and the and the part of the body where he is operating, he will make different other small ports. Okay, so that he can insert various instrument and he can insert the laparoscope. Okay, so here suppose one here and one here. So these are my small ports. So this is called as small ports. So in the first step what they do, as we told, they'll create sleeves or ports on the skin. So now what we have gained an access to inside the abdominal cavity. So we have gained an access through the abdominal cavity. Now once they do this, so through all of this they will insert a trocar. So all of this they will insert a trocar. So through the trocar then they will insert the scopes or the various instruments. Suppose these are the instruments. Okay, so this is the basic first thing. Now after this what they do, before they start the operation, one very important thing in laparoscopic surgery is something called as the creation of pneumoperitoneum. So that is nothing but pneumo is air. So we have the peritoneal cavity being made filled with air. Which air? So the gas selected here, preferably the standard is the carbon dioxide. So there are many other selection for creation of this pneumoperitoneum, but eventually until date carbon dioxide is supposed to be the most user friendly component to create the pneumoperitoneum. Many such research keeps on happening on whether the halogenous gases or nitrous gases, which is better. So based on their post-operative effect. So until date, carbon dioxide is the choice of air that we use, the component of air that we use to create the pneumoperitoneum. So how this is done or why this is done is the next question. So what they do, once they enter into the abdominal cavity, then they will pass carbon dioxide so that their air gets filled up within the peritoneal cavity, so that you can make a space between the outer abdominal layer and the inner surgical viscera. Okay, because of which you create a operative space here between the two, so that the camera can look through easily. Also that you can move the instruments easily between the abdominal wall and the inside of the viscera. So this is why a pneumoperitoneum is created. So for this again, whatever we said that they make a sleeve or a port, so this again has two methods. Actually, this is the first basic information. If you have to go into a little more deeper how this is done in two methods. So that again has called as open and closed method. In open method, what we do, they cut through all these layers of the skin in open method under direct vision and then the port. Okay, laparoscopic surgery. So what they do, through the skin they insert the varus needle into the abdominal cavity and then they push carbon dioxide to create a pneumoperitoneum. So once the pneumoperitoneum is created, now you have a good field. And why is that field needed? For a working space, so that a good working space is elicited, and also that the surgeon is able to view the operative tissue better through the camera. Okay, so this is the ideology behind creating pneumoperitoneum. Again, the carbon dioxide, what happens to it? There are certain complications. It makes the tissues there hypoxic, but but otherwise this carbon dioxide will be absorbed by the peritoneum and it will be put into the blood. So from the blood it will go to the lungs, through the lungs it will get excreted. So this is the basic way how the this carbon dioxide gets excreted. Okay, so once the pneumoperitoneum is established now, so now we have the various ports, they are already made. We have the trokers, we have our necessary, laparoscope and instruments. So especially the laparoscopic instruments will be longer than the conventional instruments. So through that you have to handle the instruments through the port. So what now? The camera will be viewing it will be giving the images of the operative part, and this camera will be connected to a video monitor. Okay. So whatever is camera image or whatever is the area that is being seen by the camera will be reflected onto the video monitor, which will be seen by the surgeon handling these ports. So visualization, he will handle all the instruments and stuff, and the operation is made, or the operative procedure is taken forward. So this is the basic method how a laparoscopic intervention happens, or the laparoscopic method of any operative procedure happens. So with this, now we have a basic picture on how we do the laparoscopy. Now applying the same to laparoscopic cholecystectomy. So now it is easy to understand laparoscopic cholecystectomy. The steps will be easier to be remembered when we know how a laparoscopic technique is generally carried out. So, okay. So for that, now as we have already seen, so the first thing, going step by step into the procedure, so it is, so the patient in supine on the OT table. So the next is induction and maintenance of anesthesia, that's the GA usually. Okay. After this, the next thing comes is, that is the traditional part preparation. Of the abdomen. And after this, now what we are doing, so now we have to make a port, that is the basic, that's the camera port. So which is the area for cholecystectomy that where we'll be doing, and it is called as an open subumbilical port, or it is it's also known as open subumbilical cut down. So imagine the same, the abdominal cavity below the umbilicus will be the first port. So this is the initial port. So this is our initial port. Now post that, so now we have our initial port that is done. Now we have to do our secondary post. So usually it is done at the subxiphoid. Okay, it is done at the subxiphoid. The other one is done at the right subcostal area. Okay, so now we have our ports or the sleeves that is done. Now after this is our next step. Is the creation of pneumoperitoneum for operation. So once the pneumoperitoneum is established, now the next step is now after this, the patient is made to lie the OT table in reverse Trendelenburg position with a slight left tilt. Okay, so with this you can expose the fundus of the gallbladder more clearly. Okay, so this is the basic. So first with the position of the patient, and then induction and maintenance of the anesthesia. We have the part prepared, and then we create the basic ports, that is the open subumbilical cut down with our sub ports or the secondary ports at the level of subxiphoid area and the right subcostal area. Now next we create the pneumoperitoneum, and then the position is changed a little to reverse Trendelenburg with a slight left tilt. Now after this, okay, now once it is on low Trendelenburg, reverse Trendelenburg with a little bit of left shift, so this will help us to expose the fundus of the gallbladder more clearly. Now, so once we find the fundus of the GB, so now the next step is retracting the fundus of the gallbladder. So now we have the crudely, if we are drawing, so this is the part. So now we are trying to retract the body or the fundus side of the gallbladder towards the diaphragm, and try to retract the neck part of the gallbladder towards the right iliac fossa. Now, why is that this part is important is that we are doing all of these maneuvers to expose what is called as the Kellogg's triangle. So, this is very important step in both laparoscopic cholecystectomy and also in open cholecystectomy. Care has to be taken that no mess has to be created at this region of the anatomical space. Now, what Kellogg's triangle is? So, this Kellogg's triangle is nothing but it is a subhepatic space at the porta hepatis of the liver. Okay. So, this space especially. Okay. Now, why this space is important? Why this space is important is that it is that various ducts and also the neurovascular bundle enter the liver, and also it is the same Kellogg's triangle which is in close association to three main things. So one is the cystic artery, then we have the cystic duct, and the next thing we have is the hepatic duct. So the next thing, once we retract the the fundus of the gallbladder and then the neck part of the right iliac fossa, we are trying to expose the Kellogg's triangle. So once the Kellogg's triangle is completely exposed, so that we can make out the anatomy very clearly before we move into the next step of ligating and cutting it down. So next, once the Kellogg's triangle is identified, what do we do next? So now once the now you identify, once we do the retraction, our Kellogg's triangle becomes a little clear, and then now what we do, we dissect the peritoneum anteriorly and posteriorly to expose the Kellogg's triangle fully. Now once we open up the peritoneum, the next thing what we have to do is identification of the cystic duct. So the cystic duct is traced, okay, completely up to the neck of its connection to the hepatic duct at the level of CBD. Care should be taken to see that the anatomy is clear before we cut it off. So the cystic duct is then completely identified. Then once the cystic duct is carefully identified, the next thing for us to identify is the cystic artery to avoid any loss of blood, okay, iatrogenic loss of blood. So next is the cystic artery. We have to make sure that the cystic artery is also traced, and next is the hepatic duct. Why? Because especially one of the major disadvantage of a laparoscopic technique is to arrest hemorrhage. This is a little difficult in cases of laparoscopic techniques because it is through these small ports that we are handling all our instruments. As in case of an open technique, it's not such easy to, that apply a pressure or apply gauze pressure, anything as such. So the control of hemorrhage becomes a little bit messy. That's the reason why all of these things should be done with utmost importance, and it is also the disadvantage that comes along with the laparoscopic procedure. So now once we are clear of identifying with the cystic duct, the cystic artery, next step what we do is separating the gallbladder from the liver blood. So now we know the important structures are safe, their anatomy is completely traced. Then we try to separate the gallbladder from its bed. Okay, so usually for safer side, it is said that around 2 centimeter of clear, differentiation must be present to avoid any injury. So the gallbladder is then started to dissect, blunt dissection, and you try to separate the body of the gallbladder from its bed. Now the next thing is, once you finish all of this, so the anatomy is confirmed, all of these are clearly traced, and now you have also separated the gallbladder. Suppose in case we have a doubt in any of these steps, so how could we identify is what we had discussed in the last session. There is something called as peroperative cholangiography, wherein during the operation itself, when the operation is being conducted, anyways you can use the try to inject the dye into the artery or into the duct, and then the films are taken when the procedure is going on, so that once the dye fills up and when you take the films, you are clear of the the anatomy, the underlying anatomy, so you are sure where exactly is the structures running. So in case of doubts, we could take the help of peroperative cholangiography. Now once all of this is done, then carefully the cystic artery, cystic duct, everything is clipped. They are clipped and then they are removed off. So now we know that the cystic artery, the cystic duct are safe. So it cannot be like in the basic thing with respect to when you're dissecting a part of it, the first thing is to make sure that you ligate the proximal part to avoid any leakage. So that is why you first clip it off and then remove the next part of it. Okay, so then the gallbladder is removed out through the umbilical opening. So this is with respect to how the laparoscopic cholecystectomy is done. So starting from the patient's position on the table, so now we saw until pneumoperitoneum. Now once the pneumoperitoneum is established, then we saw how to identify the Kellogg's triangle, for which we need to a slight maneuver of retracting the gallbladder towards the diaphragm and the neck towards the right iliac fossa is necessary. Once the Kellogg's triangle is exposed and once the structures of the Kellogg's triangle are made, are safeguarded, then finally they are clipped and cutted, and they are cut off the anatomical C2, and then finally the gallbladder is removed out from the umbilical port. So this is how the laparoscopic method happens. Now, very important thing what we have to assess after this is the post-operative recovery. Okay. Now in many cases, so we saw the operative and now is the post-operative phase. So as many as patients, they recover within 24 to 48 hours of surgery. Now suppose there is no recovery, then what are the things we have to think of is, one is axis injury. With respect to laparoscopic techniques, it's called as axis injury. How an axis injury can happen? While we are inserting a varus needle, an injury could happen. While you are trying to introduce a trocar, it could happen. While you are moving your instruments within, there is all chance that you, without expertise or skill, or maybe many times without the knowledge, you could injure the nearby tissues, because of which there could be an inflammation. The second thing with respect to why a post-operative recovery is delayed is, first thing is access injury. The second thing is bile duct injury. So during the procedure, if there is an injury to the bile duct, then you could be thinking about a bile leakage that could have had happened, and that's why the patient's condition is deteriorating and it is not patient is not responding or coming to a quick recovery. Now, in many cases, what happens is there is something called as post-cholecystectomy syndrome. Okay, that is, it is seen that in 15% of patients, they will not find any relief for which, with the method adopted. That is, now suppose because of so and so symptoms, the patient has undergone cholecystectomy. But in many cases, what happens, in 15% of patients, what is statistically seen, they will find no relief even with the operative intervention or even with the treatment protocol. Now, why this no relief phase could happen? So there are certain reasons of why in these 15% of patients there could not be any relief. So the first thing what is we have to look for is, now during surgery, suppose accidentally a gallstone has moved into the common bile duct and this is missed during surgery. So this is one reason. Okay, that is gallstone in CBD, which is called as choledocholithiasis. If this is missed, then there is no relief even if the person has undergone the removal of gallbladder. The next thing is, if a stone is present in the stump of cystic duct. So when we saw previously, there is a ligation and then there is removal. That is the rest of the portion is cut off, right? Now at this stump level, suppose a stone has been lodged and it is missed while this process is happening. Even then, what happens? Even though you have removed the gallbladder, then there is no relief from the procedure. So this is the second thing. Now the third thing is, suppose during the operation you have made any damage to biliary tree. So in all these three cases, there will be no relief even after a cholecystectomy. Okay, so this is one thing that has to be observed in post-operative time beyond 48 hours. So it is very important to observe the patients to see the success of the operative procedure. Okay, so after this, what happens? Now suppose like we have with investigations, or we have ended up in a situation where the patient is not recovering even after 48 hours. So what is that? We have doubt of all of these things in mind, but we are unsure of what to do next, and the patient is not recovering from the operative procedure. So in such cases, what we have to do is immediately go for an ultrasonography, so that this gives the measurements and dimensions of either the biliary tree, the bile duct, okay, in complete, so that we can identify where exactly is the cause, or what is exactly the cause that is creating this. Now, suppose what happens, suppose during the operation we have left, there is a stone in the CBD that has been missed. So, which has been picked up by the ultrasonography, because of which, there is a dilatation in the CBD, okay, and that has been picked up. So, what could be the intervention immediately to relieve? So, we could go for an ERCP. So, this ERCP was discussed in the previous session. Suppose if if this has been missed, we can go back to the previous session and get cleared of it. So in ERCP, what we do, this ERCP is not just a diagnostic protocol or a tool, it is also a treatment option also. So with ERCP, what we could be doing with that, with the balloon stenting, there are you could also see where exactly the obstruction is, and also with the Dormia basket, the stone, as we had seen in the last session, the stone is removed. So once the stone is removed, the irritation goes down, and whatever is the bile collection, that also gets relieved, and there is bile drainage, and the patients come back to good recovery. So this is with respect, suppose if there is obstruction at the level of collection in the subhepatic, to allow the collection come out. This could be done under the radiological guidance. Suppose if the collection is very small, then it usually doesn't matter. It gets resolved on its own. Suppose if there is a large amount that has to be drained out, then a drainage could be placed. So the next thing, what is, suppose if there is the biliary tree is injured, because of which there is bile leak outside, and that is why the patient is in a poor recovery. In such cases, now suppose the patient is already debilitated, we cannot go for an open procedure. In such cases, a simple technique is a stent could be placed in the same position, because of which it would also avoid the leak, and it will also help the flow of the bile. So once the patient comes back to a good state, then we could turn we could adopt into a definitive surgery at later stage. So these are the immediate post-operative interventions we have to look for to bring back the patient from bad recovery to a good recovery. Now, in many cases, one thing we have to see is only 15% of the common bile duct injury or the biliary tree injury is being picked up at the OT table. The rest 85 is always, it is being picked at the post-operative phase or the recovery phase because of all of this. Now, suppose if there is, you have put a drain already. How do you identify, there is bile leak? So suppose if a drain is there, it is very important to keep observing the content of the drain. What is the quantity of the drain at regular intervals, to see that itself will give an idea on what is draining out from the inside of the body cavity. So suppose we find bile inside, then that's a clear indication that there is an operative injury to the biliary tree. Or now suppose a drain was not placed operatively, then what happens? If the bile leaks, then that will cause bile peritonitis. So then the patient would exhibit signs of bile peritonitis, and he'll end up in a stage of shock. So this is with respect to bile peritonitis, or when if there prior, it could deepen the obstructive jaundice. So these are the signs through which we can pick up the biliary tract injury. So this was with respect to laparoscopic cholecystectomy, how it is done, what are the probable complications. Than the operative techniques, what is important for us is to know the complications associated with the surgery, so that we are able to pick it up at a faster pace. Now the second thing what we see with respect to cholecystectomy is the traditional method, that is the open method of cholecystectomy. So for this again, where is the incision made? So for open method, the steps are the same. The basic the moral behind the operative technique is also the same for both operative and laparoscopic method. The first thing is to identify the Kellogg's triangle and to dissect the structures carefully. So this has to be kept in mind with both the techniques. So in laparoscopic techniques, where the incision is made, so we make a upper transverse incision is made, and it is made at the lateral border mid of and it is made at the lateral border of the rectus muscle. So this is the anatomical location where the incision has to be made for a open technique. Now once the incision is made, so the next thing what we will be doing is packing the structures around. Now the incision is made, it is open, we have the surrounding structures. So these are packed, like we have the hepatic flexure of colon, we have the duodenum coming there, we have the lesser omentum. So all of these, so that they do not intervene into the operative field, they are retracted or they are packed, and they are, usually they are retracted using the help of the hand, or there are something called as ring retractors. So using these, they retract the surrounding structures like hepatic flexure of colon, duodenum, and the lesser omentum. Basic important structures, the nearby structures. So once the ring retractors is used and they are packed and the gallbladder is kept in position, the next thing what is done is, so the special forceps used here to retract the gallbladder is called as the dual forceps. So using the dual forceps, the dual forceps are used at the infundibulum of the gallbladder, and the peritoneum covering at the Kellogg's triangle is put to a stretch. Now if this is the cystic duct, we have the neck, so we have the body, we have the fundus. If this is the neck, this is the infundibulum part. At this place the dual forceps is applied and a stretch is made at the level of peritoneum. Why? To dissect the peritoneum. Even in laparoscopic method also we had dissected the anterior and posterior parts of the peritoneum to access the Kellogg's triangle. So here also, using the dual forceps, the peritoneum is stretched. Now once the peritoneum is stretched, the next thing is it is divided very close to the gallbladder. The peritoneum is divided very close to the gallbladder. Now once the peritoneum is divided, the next thing is identification of the Kellogg's triangle. Whatever is the fat that is present at the region of Kellogg's triangle, they are also dissected out, and then again we expose the cystic artery and the cystic duct. Now once, suppose in confusion, as we said, one is the peroperative cholangiography, or there is also called as retrograde, I forgot the word, there is something called as retrograde mapping or something, wherein through the gallbladder gallbladder is able to you are able to identify. So with the help of the gallbladder, you trace backwards to identify the anatomical structures up to the level of the cystic duct to the level of the common bile duct. So with that, we can identify, we can expose the cystic artery and cystic duct. So once you are very sure of the anatomy, and then we ligate and it is cut between the sutures. So that there is no spillage into the area. So this is how in both the procedures, where the cystic duct and the cystic artery are the two important structures that we have to keep in mind before we dissect the gallbladder out of its situ. In both the cases, there are not 2 to 3 basic things that we have to keep in mind. Is one important thing is identification of the Kellogg's triangle, very must in cases of when you are operating for gallbladder. The next thing is, suppose you are not able to identify the contents of gallbladder, you are not sure about the anatomy, you should never continue with blind dissection. So the dissection has to be stopped and no blind dissections has to be continued. The next important thing is, suppose during the operative procedure bleeding happens during an open access, open operative procedure. So in that case, at the level of calot triangle or very close to the bile duct, you're not supposed to apply, you try to control the hemorrhage with pressure that is applied, and you're never supposed to go for a blind clamping. So this has to be avoided at the region of Kellogg's triangle, because there are various neurovascular bundles that are also associated at the same site. So that is why, in case of doubt, never has anything to be continued under blind assumptions at this region is the important rule that has to be kept in mind when we are operating at the level of Kellogg's triangle. So again here, after this, the post-operative complications again is same for the open method or the closed method. Even during the open method, there are all chances of missing a stone in the common bile duct. There are all chances of injuring the biliary tree. So most of these could happen at the open method also. So the post-operative complications remains the same. There is one thing, something called as Mirizi syndrome. Okay, it is called as Mirizi syndrome. Now, what is Mirizi syndrome is, at times what happens when the cystic duct, okay, when cystic duct, it is in close association to the, the body of the gallbladder is, or when the cystic duct is very adherent to, it's better if we okay. Now suppose if this was the cystic duct, so anatomically there are various variations how a biliary tree or how the gallbladder along with its tree presents. So suppose in many very rare cases, what happens is that the cystic duct will be in close conjoined space with the common bile duct. So in such cases, what happens, we have the neck, we have the infundibulum here, and then we have the body of the gallbladder. So in Mirizi syndrome, what happens is that there are chances that the gallstone enters into the common bile duct through, corroding through from the infundibulum to the common bile duct directly. Okay, so that is what is called as Mirizi syndrome. In such cases, what we have to do, we have to open the infundibulum and clear the contents there, and also make sure that the common bile duct is also devoid of any gallstones, and then it is sutured back and the gallbladder is removed. So this is one a rare condition that that can be kept in mind, associated to the other topic of discussion. So in today's session, we saw how basically a laparoscopic method is carried out, what are the basic interventions, so starting from the main port to development of the pneumoperitoneum, and then we, with the background of laparoscopic surgery, we then saw how a open cholecystectomy, that is the laparoscopic cholecystectomy is done, and how a open cholecystectomy is done. In both the cases, one important thing to be kept in mind before we dissect the gallbladder of the C2 is the safe dissection and safe handling of the contents of the Kellogg's triangle, and to keep in mind that the cystic artery, cystic duct and the hepatic duct are not injured, the biliary tree is not injured, and we have not left contents being leaked, or we have not injured the bile tree so that the contents are leaked outside, which that is causing a post-operative infection. And after that, we saw how a post-operative recovery field has to be thought of or has to be kept in mind. If the patient exceeds more than 48 hours of recovery, then what are all those factors that we have to keep in our mind to go for a correct diagnosis and immediate intervention to help to rescue the patient is what that is also we have seen. And we have seen certain important things or rare terminologies like Mirizi syndrome, etc., that comes as a part of the pathology. We also saw acalculous cholecystitis in today's session. So in the next session, we will further continue along with the other pathologies of the gallbladder itself. So we'll conclude today's session again with a shloka. Om Namami Dhanvantarim Adidevam Surasurair Vandita Pada Padmam लोके जरारुग्भयमृत्युनाशं दातारमीशं विविधौषधीनाम् ॐ शान्ति शान्ति शान्तिः. Thank you.